Hi and welcome to Policy Unpacked, a podcast by Global Policy Network. In this series, we dive into the policies shaping our world, from healthcare to sustainability to education, and explore how these critical areas intersect to drive meaningful change. Whether you're a policymaker, a practitioner, or just policy curious, we're glad you're here. Let's unpack policy together. My name is Ameneh Ghazal Saatchi. I'm the founder and CEO of Global Policy Network. And today's guest is Stephen Riley, Deputy Chief Regional Pharmacist for Pharmacy Integration at NHS England Northwest. Stephen has 18 years of experience as a registered pharmacist and has led services across the community, primary care, and regulatory pharmacy, in addition to working at a national policy level. He has overseen medicines optimization in a large CCG, shaped contract assurance for NHS England, and served as a policy lead, bringing both depth and breadth to his leadership in pharmacy. So hi, Stephen. It's lovely to speak to you today.
Hi, it's great to be with you, and I'm really excited to be an associate part of the Global Policy Network.
Thank you. And tell me more, because you've held loads of roles across community, primary care, regulation, and national policy. What first drew you to policy, and how did your journey lead to integration work at NHS England?
Yeah, it's, as you said, I've been qualified now for just over 18 years, so my journey towards pharmacy started quite a long time ago. It actually stems back to when I was looking to what to do for my choose for GCSEs and A-levels in school. I'd always been interested in science-related subjects, but I've always, I think partly because the ethic from the way my parents work and the jobs they did, I've always had an interest in working with and helping and supporting people. So when I went to a careers talk around pharmacy, I saw it as a fantastic opportunity to be in a position where you can have a direct impact on supporting people's health and care, but also there's a great opportunity within the profession to work in many different facets, from a range of areas, from direct patient care, academia, industry, policy decisions, and commissioning roles. So we've seen such a variety. It was a great opportunity to a great profession to be part of. So that's what really drew me to the profession and started me off on my journey more than years ago. In terms of the role I do now with integration work at NHS England, I've done quite a very career. You've obviously read out in this will start there. I like variety and doing different things within my career. So I've worked in different sectors. I've always had an affinity for community pharmacy. Whilst I was doing my A-levels and finishing them off, I actually worked in a small community pharmacy. I actually got my first experience of pharmacies in real life and actual practice. So as I worked through my different roles, I've always had an affinity for that sector, but I've really enjoyed the roles I've done. I've worked in clinical support roles and supporting patient care in different ways. It was around 2014 I actually got involved into working at a higher commissioning level, leading the meds optimization function for a CCG, and I really got an affinity, enjoyed the working at that level, developing policy for the organisation, developing wider programs and across the whole sector, supporting whole populations of patients and taking things wider. And an opportunity came up to move into NHS England and actually be part of, at the time it was the Greater Manchester Health and Social Care Partnership, as one of the first devolved healthcare economies. And it was a great opportunity to move into that arena and develop my understanding around pharmacy service commissioning, assurance, also wider primary care delivery. And in that role, I had a great part in actually pharmacy service development around the regional level, and start to look at then how we could actually better utilise pharmacy services and stitch them into other primary care services and also wider health services within that footprint. And that really led me into the interest and passion for actually trying to develop integration and integrate pharmacy into wider roles and into wider healthcare pathways. And I'm fortunate now, so in my current role as a Deputy Chief Pharmacist for the Northwest, my primary function is working to actually support the integration of pharmacy into those wider healthcare pathways, but also being a conduit with the national pharmacy team in service development and pathway development at national pharmacy level as well. So it's a great opportunity to combine both commissioning oversight, integration and quality of pathways, and bringing expertise into those roles.
And you've been part of major structural shifts in pharmacy. So looking back, what's a moment or project that you feel has most shaped your professional outlook?
you're quite right. I mean, it's been quite significant structural shifts in the pharmacy profession. I think what's really shaped my professional outlook overall is the opportunity I've had. I think when working through previous to NHS England, I worked for quite a while with an organisation, the Pharmacist Defence Association. They was partly doing indemnity provision, but also a trade union for pharmacists. And with that organisation, did quite a lot of work and worked at national level with them, developing policy to support and expand the profession, develop opportunities and ideas. That really helped shape some of the ethos about how I can use my skill set and how we can try and influence elements to develop the role of the wider pharmacy profession, but also develop how it's valued and how the services are delivered safely and effectively, and take the understanding of what the environment's healthcare professionals work in into wider policy development. And that's really, I think, one of the key professional milestones for me in terms of my outlook is and the ethos and what I take through this. Every time I'm working now at my either regional level or with national colleagues to develop either policy ideas, service ideas, the main thing to keep in the centre of the mind is always the patient-centred elements and the patient impact. But a strong element to bring with me is also that one eye on how will this work in reality, what would this be like for the professionals delivering the services, and making sure that we've got their understanding of the environments they work in, how we can make it a reality to deliver the policy needs and take it from a national ambition to actually what's it like to deliver that in reality at frontline level, and also have that eye on what would it be like for those colleagues and how to deliver these services and how we can support them.
And where do you believe pharmacy truly sits in the healthcare system today, and where should it sit?
I think with pharmacy, so as a wider profession, we've got a great role in being the gatekeepers to how medicines are utilised, how the resources are spent, how medicines are used safely, effectively, and wider healthcare delivery. I think that role's expanded considerably over the last 20 years or so. Particularly, we've got significant expansion now. Pharmacists working through our GP practice roles, working through medicines optimization teams, significant clinical teams and trust settings, hospital trusts and specialist trusts. And the role of community pharmacy is massively expanded. Community pharmacy is one of our largest sectors. And I think traditionally it's been seen as a retail arm and not necessarily part of the NHS. Now, that's by both the public and I think some commissioners, some healthcare providers. Interestingly, if every single primary care provider, so doctor, dentist, optician, and pharmacist, they're all actually effectively independent contractors that hold a contract for NHS service delivery, so even your GP. So we're as much a part of the NHS as anyone else is in that respect. But I think the role has significantly shifted towards a more clinical focused delivery, and we now have a much bigger role in the variety of clinical services we provide and a greater opportunity to be involved in all health population support, preventative measures, hypertension case finding, for example, identifying people at risk who are not currently identified, not currently diagnosed, and really helping prevent significant cardiovascular disease. There's a raft of work around taking medicine safely and effectively, and we've now done a lot more work around the pharmacy first and supporting patients with clinical with them minor conditions which could become urgent care needs, and making better use of healthcare resources in our wider health systems. So we've had a significant expansion of how pharmacy is part of that wider NHS plan and delivery. Having said that, I think there's a lot more we could be utilised for in terms of and how we're viewed. We could be stitched in much better. It goes back to the integration work I do. Pharmacy services are still very much almost like disparate compared to healthcare pathways, and we could do a lot more to integrate them and make them a better part of the healthcare journey and healthcare pathway for patients within our care systems. And there's a much bigger role we can have there, I think, in terms of how services are delivered and how services are developed and commissioned. And we can be, I think our pharmacy colleagues and teams could be utilised a lot better, and a lot more needs to be done in terms of how we support the infrastructure and also the certainty of service commissioning as well. So we've come a long way, but I think we can be much further. I think I'd say probably closer to the table rather than being at the table. We should be at the table, but we're on the way to getting there. I think there's a lot more to do, but there's a lot of achievements and progress.
And just on that note, community pharmacy often feels left out of the big picture NHS strategy. How do we change that narrative?
So I think there's a number of elements to this. So one key thing is actually work through our pharmacy leaders and our influential, the influence we can have. So leaders of the profession, and particularly some of the great colleagues who I work with, who are ICB chief pharmacists, and other key colleagues who are also associates with the Global Policy Network. I think how we utilise our influence to make sure that people fully understand what the sector delivers, how we deliver things, and make sure they understand what the ability is, and they see the good results. So we make sure we showcase what we deliver, utilising information and data about service delivery intelligently as much as possible. So make sure we identify the patient benefit, patient outcomes, and how we support our communities and the benefit from what the service delivers, and also the value of what could be delivered through pharmacy and how things could be utilised better. And I think other key thing, as well as organisations such as GPN, is that when we're developing potential policy pieces and things of that nature, showing how we utilise and show the value of pharmacy and the community pharmacy sector in our health systems and how that can be better expressed. So it's also showing the value as well. It's not, so it's not just a number of patients walking through the door. What does that mean for a health system? How have we contributed to preventing serious secondary diseases? Or we've identified people with hypertension, we potentially prevented X number of strokes, or things will be very costly to the local health service as well as detrimental to the patients and their families. And I think how we stitch in that wider value of what we deliver is crucial to us moving forward and getting a better seat at the table.
And with more professionals gaining prescribing rights, how do you see this shift in care delivery in integrated systems?
So I think one of the key projects I'm currently involved in is in my day-to-day role is the independent prescribing pathfinder and community pharmacy. So it's done at national level, but we've established pathfinder sites and programs in each integrated care board and ICS system. The work we're doing now is to look at how we can introduce prescribing services through the community pharmacy setting with community pharmacists. So it's not looking at could a pharmacist prescribe, but actually what do we need to make a service available, and how could that operate from everything from a clinical governance perspective right through to a pragmatic, logistical, what computer system do you need, how do you set a cost centre up, who's going to pay for the medicines, how will that be distributed. So that brings a lot of valuable insight and information about how that would work on a more wider commission scale in the future, either through an ICB or some of the national plans to potentially commission through national services. So as pharmacists, and also with pharmacists, from next year, every new pharmacist that qualifies will qualify as a prescriber from day one with that prescribing ability. So we've got a much bigger bank of health professionals who have the ability to prescribe. What I can foresee is that we can develop a lot more accessible services for patients, and particularly hard to reach patients don't quite visit the GP practice or may need to go outside of different hours. There's an opportunity to have better long-term condition management and wider long-term condition management done through a community pharmacy setting, for example. There's a greater opportunity to have more acute conditions managed through a community setting rather than having to go to either wait for a GP appointment, go to an urgent care centre, or sorry, we're being tapped by a fly. Urgent care centre, or some people go into an A&E centre unnecessarily. There's a greater opportunity to make better use of our resources, and a big thing is actually how we can achieve that 10-year plan shift from prevention, treatment to prevention, but also from hospital settings into community settings. There's a greater opportunity to utilise the primary care sector better and expand that access point for patients.
And if you could redesign pharmacy education or CPD from scratch, what would be non-negotiable for the next 10 years?
That's a good question, that one. I think the key element to me, I think there's a lot of work being done currently with the universities and with the initial foundation training programs to incorporate more clinical hands-on experience and expertise and more clinical focused training to account for the new role that pharmacists are going to need to do and we want them to do in the future. I think for myself, there's some key elements that include, as well as that more fundamental clinical hands-on ability, it's also instilling in people some of the patient ethics and the governance elements of things, because it's all well and good accrediting people to have the ability to prescribe from day one. But if you look at people with longer term experience who've got that expertise of practicing in reality, understanding where their professional boundaries lie, where their competencies lie, how to push back and appropriately and effectively say no when they may be being asked to do something that's not quite correct clinically or safely. And that could be to a non-pharmacist, non-clinician management figure. It could be to another healthcare professional expect you to do something on their behalf. I think it's instilling that support and understanding of the importance of understanding their professional boundaries and utilising their professional abilities and their responsibilities as a qualified healthcare professional when they come out, and really give that good grounding to support people, particularly people coming newly qualified into the profession. That's a really key thing to help support them. Also, the likes of our pharmacy technician colleagues now, they've got the ability to deliver services to patient group directions. It's given them the support and education to supplement their training to make sure they're able to do so confidently and competently. And the work is underway now to allow them to deliver more through PGD, through nationally commissioned services. I think down to CPD, things to make sure they have that ability built into their training programs as technicians, but also help support them as qualified technicians to fully develop and expand their role and do it safely, and give them the confidence to do that role really well.
And how do we ensure that pharmacy integration efforts genuinely tackle health inequalities rather than reinforce them?
So I think a key element for this is it's utilising intelligent use of data. So it's understanding where our pharmacy is based. So where we've got pharmacy services and accessibility, particularly in areas of high deprivation, areas where there's not as many other services available to people. Understanding I think big key things were diversity as well, and understanding the multiculturality of our populations that we serve, making sure we understand. So it's people are sensitive to cultural needs when they're delivering their healthcare needs, and so they understand the populations. Understand people may have different approaches to things. People may find certain treatments or medicines more acceptable than others. How we deliver and engage with people is quite different. How we engage with communities. Making sure people have access to translation services effectively, because quite often pharmacy can be left out of that element and make it quite difficult for people to get appropriate care when they need it. There's a lot of work being done around inclusive pharmacy practice and understanding the diversity of our workforce and developing that element of inclusivity, but translating that into supporting and understanding the diversity of our communities and culturally sensitive healthcare delivery. There's some really key elements to that understanding of what our populations look like. Also then further using data to understand who's using our services. So are we serving age groups effectively? Are we serving different cultures effectively, different genders, raft of different elements? Are any parts of the population being missed out? Not making generalizations as well for service delivery. And then the key thing really on the integration aspect is that it's stitching the services as part of wider care pathways, thinking about the patient in the centre. So let's build our pathways around the patient, not what's convenient for the local health economy, what's convenient for you as a patient or a member of the public. So you've got a clear journey, clear pathway. You're not being sent to 4 or 5 different venues unnecessarily. We can time as many things as possible in one go. We can make things more efficient. Make it easy for you to access certain services, and also make it part of your pathway. So we mentioned before, we've got different pharmacy services and a bit disparate compared to other services. Well, let's think things logistically in an integrated fashion. You come to a pharmacy for a general checkup, we may identify you could have undiagnosed hypertension, get you diagnosed by the GP, they start you on medication. Let's stitch you back into the new medicine service of the pharmacy and make sure you can use that medicine effectively and properly. But then make sure the pharmacy is able to do that in a way that meets your either cultural needs, language needs, patient-specific needs, and it's all tied up. So there's a lot we can do there to try and help tackle health inequalities rather than making them more disparate and wider.
And I'd like to talk about neighbourhood care now, because it's quite a big theme in the NHS. What does neighbourhood working really mean in relation to medicines optimisation and local care delivery?
So my understanding, so we've currently got a setup within localities as part of integrated care systems of primary care networks. So they were set up under the last government, and largely they are working groups of GP practices that deliver care for those very localised population needs. And the patient population of around up to about 50,000 or so is typical size. So that's largely based on the GP practice delivering in that area. For me, the neighbourhood element is a similar size population, but it's bringing in the wider healthcare services available in that area. So it could be pharmacy, dentistry, optometry, other health professional services in that area, and working as a multidisciplinary team to deliver care for that patient population. And again, part of that will be having good communication pathways, service integration pathways to make sure we've got good understanding how that operates and work together, who's best placed to do key roles. And there's a great opportunity for pharmacy there to, around the medicines optimization approach. There's some key community pharmacy services that can be utilised within that immediate area for patient support and advice, making best use of those medicines for the patients, make sure they're getting the medicines safely, effectively, potentially a role around cost efficiency as well, and linking back in with prescribers as well to support formulary decisions. And that there's a wider piece then as well about linking in from some expertise around how medicines are used, as in making sure the proper review is done on how medicines are prescribed and spent within that neighbourhood and how the resources are utilised through wider medicines optimisation efforts and pharmacists working in GP practice as well as other areas. So there's a great opportunity within that small, relatively small population way of working, but bringing in much wider healthcare professionals and multidisciplinary approach, and it really complements services that traditionally been provided through a PCN route. We can really expand upon that and deliver well.
And how do we move beyond the transactional model of pharmacy towards a more personalised care model?
So I think we've started that journey already, as I mentioned before. So particularly from a community pharmacy perspective, we've got a much broader range of commissioned services now, more clinically focused service delivery, as opposed just to the traditional medicine supply element, which is a very important element. It's a lot more than just handing a prescription out, and there's a lot more to making sure that medicine's safe, effective, and correct. But I think the big change in how we move that is it's utilising that time with patients. So when you're making sure you're linking services together for people, so somebody may be coming to pick up a medicine, but actually, you may notice they've not had a respiratory review for a while. If you're commissioned to do that, you can bring that element in to review that patient's care. If patients being prescribed a new medicine, you can bring in the new medicine service to really do that follow-up support with them, supporting people being discharged from hospital recently, identifying people with blood pressure needs, and then you've got the wider health support and advice from a pharmacy setting. There's real good opportunities now to deliver what we have as a bundle of service offering to patients, rather than just a transactional, I've been to the doctor, I'm just going to come and pick this up quickly. I know traditionally there was a generalised view of people felt shortchanged if they saw the GP and they were seen and kicked out within 5 minutes, and if they weren't given a prescription, they tend to feel shortchanged. The flip side is if you come to community pharmacy, if you weren't seen and out the door within 5 minutes, people felt like they'd been shortchanged and they spent too long there. So it's very much, a lot. It's going to be still much more to be done, but I think we're definitely on the journey now to people seeing their community pharmacists, pharmacy technicians, and their wider team as additional healthcare support, healthcare professionals who give them the expertise and advice. Also, the people they may go to for the initial support and advice, particularly with the Pharmacy First service and the campaign support we've had back from national level and other local work. Patients are now seeing the pharmacy as the first port of call to go to. So it's being recognised more now as a place to go for healthcare support rather than just a transactional, let's get my medicine and get on the way. So that journey's definitely started. There's more to do, but we're definitely on the right way for that.
And now let's talk about innovation. So how do you see digital transformation like shared records or tech-enabled services supporting better pharmacy integration?
Yeah, so the digital transformation element is crucial to making integrated care work. Without it, it's not going to happen. We've started this journey, and a lot of work's been done quite significantly through pharmacy in the last couple of years, which has enabled access to better shared care record access, so they can actually directly view key elements of the patient's GP record for information to understand what wider medicines people are on, what other conditions they've got, what tests they've had recently, which will really help support them in making care decisions when the patient comes to the pharmacy for a service. We've also had a lot of work's been done to allow more recently an update in the GP record when the service is being delivered. So work's been done now to enable that record to go directly into the GP record, which has really helped again reduce a lot of the admin side of things from the pharmacy side and the GP practice side. So they're all really key elements. But what's really positive as well, we've seen is wider developments at integrated care board and care system level, where they develop their own shared care records. One of the areas I work in Greater Manchester, they've got a Greater Manchester shared care record, which it also includes secondary care hospital trust information and social care information. So it's a much broader record that the pharmacy can access to give that much richer view of the patient and provide more holistic care. Other technological advances are really essential as well. So we've also got elements around recent developments around prescription tracking availability for patients. They can use the NHS app to see where their prescription's up to. So once it's not just is it being prescribed, has it been dispensed yet by the pharmacy and things of that nature. So again, that's all key information. And then as pharmacies moved into the last, probably since the pandemic and the bit before, moved into more remote and digital healthcare delivery. So it's systems to enable them to do remote consultations with patients as well are really key. And that's a really important factor. So digital is really, I think, is really crucial to our delivery of care for integrated care for patients, and try and tie that loop up and try and have a single care system approach rather than disparate systems that don't talk to each other.
And with ICBs having to do more with less, how can medicines optimizations teams balance cost and quality?
This is a significant challenge. And obviously, I mean, we're always asking the NHS to do more with less, and the resources are always very limited. And I think people are appreciating that more now than ever. There's certainly a squeeze on medicines budgets and ICBs, as well as obviously the current restructure that's ongoing now. There's a requirement for ICBs to significantly reduce their running costs, as well as changes to NHS England. I think a lot of work that's been ongoing through ICB teams is effectively utilising their workforce and their leads around engagement with prescribers in both primary care and secondary care to actually prescribe elements within formularies, try and make most cost-effective medicines choices. They've got large-scale change programs where they've identified medicines that may make a significant efficiency by doing wholesale changes. But you need to balance that then with the impact on changing the patient's medication, make sure it's clinically appropriate and safe. There's key elements though around, as well as making sure you prescribe efficiently within formulary guidelines and also not being wasteful and over-prescribing. There's also an element to make sure that you are treating people effectively and you're not under-prescribing as well, so to make sure we've got the right quality, so people not only just prescribing the most cost-effective thing, are they prescribing the most clinically effective and the best evidence medications? Have we got services set up in a way it's got the right governance and right oversight approach to make sure that people behave and deliver services in the right way with the patients at the heart of the service? I think another key element as well, it's doing reviews of people on multiple medications and polypharmacy. Are people being prescribed medicines because of a side effect of a side effect of a side effect, and quickly go from 1-2 medicines to 10? Can we reduce some of that unnecessary burden on people and take some of their medicines away and reduce that down? That'll save some money as well, but it'll also do better quality of life for that patient and better quality care. So there's quite a raft of avenues people can work through to try and deliver this. I know medicines optimization teams and our ICS chief pharmacists who are leading this are doing a lot of hard work to deliver this. But then it's also, again, the work utilising the service we've got available. So for community pharmacy, for example, by stitching those services in, like a new medicine service, when people's prescribed a new medication, let's actively refer them into that service, and then they can support patients with the use of that medication, because the biggest wasted medication is the one that a patient doesn't understand how to use and puts in the back of a cupboard or takes at the wrong time of the day in the wrong way. So let's effectively help patients to effectively use their medicines and address issues early. That in itself will also improve the efficiency and cost effectiveness as well.
And let's now deep dive into your role at Global Policy Network. So you are an important part of GPN. As an associate, you're helping us to construct our roundtable on the 8th of September on workforce and efficiency. So tell our listeners, what excites you about GPN's mission and vision, and what got you involved?
I think the key element for me, it's that approach to try and develop an evidence-based policy approach, but being an independent, so I made the think tank the right way, but being an independent organisation. So it's not just a standard consultancy where we're being paid to come up with ideas because of someone's preconceived ideas. It's a genuine approach to try and develop some of the best policy ideas and approaches and shared solutions to some of the biggest challenges we face in healthcare. Also, what I really like about it, it's that global approach as well. So it's having that such a global reach and bringing in expertise and colleagues from all different parts of the world, so we can learn from each other and take those ideas. And what I really think is really exciting as well, it's the learning culture with the organisation. So it's bringing people on for either fellowships or different parts of their policymaking journey and career. It could be either an expert policymaker who's come to do a significant substantive role, or it could be someone starting out in policy who wants to learn more and do either fellowship or things of that nature. It's to have that opportunity to support people's journey, but make a potentially make a global difference to how healthcare is delivered. That's a really exciting opportunity, and it's a great novel way of trying to bring that together from either traditional consultancy or traditional think tank. It's a great novel way of doing things.
And what can listeners expect from you and your work at GPN?
So my expertise is around the pharmacy and service integration element. I think from my perspective, it's the work I'm hoping to achieve is certainly have a really support and influence the policy developments, not just around pharmacy itself, but also how pharmacy is part of that wider healthcare delivery and wider healthcare network. Integration is a big element of the work I do, but it's the wider taking the principles of what I have and the abilities I've learned over my time, my career, and how to bring that into a wider policy piece, and how pharmacy can be a bigger piece of the solution and a bigger support. So in terms of what to expect from myself, obviously I'm working hard to be involved in some key projects. I've chaired one of the roundtable on the 8th of September, future workforce elements and efficiencies. Is really excited about how we can explore that with some key colleagues and some great speakers. Also being involved in some of the wider policy work developments. And I'm also looking forward to the opportunity to help work with some of the fellows and try and support some of the mentoring as well, and help bring on policymakers of the future, and help some of my small level of expertise can maybe help influence and maybe help support other people as well. So some of the key things I'm really looking forward about delivering as an associate with GPM.
And finally, who would you like to see on this podcast in the future?
I've seen the list so far. We've got some great people there. I think, it'd possibly be really good to see actually some of our national leaders as well, to get their views. So obviously we've got our Chief Pharmacist, David Webb. There's each of the devolved nations have a Chief Pharmaceutical Officer as well. I think a couple of people that need to be really good to see some of those key policymakers to get their vision and views, and to see how we can work with them and work to deliver some of that elements as well.
And we're going to go to our quick fire round. So what in the healthcare sector would you change tomorrow if you could?
I think one key thing for me would be interoperability between different systems, between secondary care, primary care, and also between the different primary care providers, so we can actually really stitch things up and try and make that work better.
Tell me about someone, whether it's a person you know or a public figure, that has inspired you.
I think quite a few people in my career. One person really in my professional career is actually our regional chief pharmacist, Karen O'Brien. I worked with her currently now. I'm one of the deputies, but I've known her through much earlier on in my career, and she's the type of person who's always had a mentoring approach to supporting people and bringing them on. But that's been really positive from a professional perspective. But from what she's delivered in terms of innovation and trying to bring people together to work in new ways and deliver key elements and inspiring others to work together more effectively, that's been a great blueprint about how to operate and run things. Has been really positive influence on me professionally, and the personal ethos is really positive as well.
Tell me about a book you would recommend and other aspiring healthcare leaders to read.
The book I've actually just recently finished reading, that was really helpful and useful, was No BS Leadership, and it's by Chris Hurst. It's a really useful blueprint. It breaks down how to be an effective leader, but does it in simple terms. And the biggest element of it is, as a leader, when you're developing a strategy, you're effectively trying to establish where you're on point A and where you want to be point B, and then the journey is how you get from A to B. And it just cuts through a lot of what's traditional, nice to have airy-fairy language, things of that nature, and it really just brings down to the bare level of what your job is as a leader and how you can achieve that. And it's been a really it's really effective. I found it was a really effective book, to be honest with you. I'd really recommend anyone want to be, it doesn't matter just what sector you're in, it's a really positive. I know the really positive thing with the book as well, it's not just talking about people who are high-level CEOs of big corporations. These could be community leaders who are running the local kids Sunday league football team. So it's all about leadership in all levels and how you can actually work to be a leader from where you are. It's really, really positive book to read.
Do you think healthcare professionals get given enough leadership training in the NHS?
I think there's opportunities available to people. I've been fortunate in that I was able to recently undertake my master's in health policy, and that was as part of an NHS programme. So there are certainly options there, and there are other, and there's the NHS Leadership Academy. There are courses and things you can do to support people. I do think those health professionals, more could be done with leadership, particularly for the undergraduate degree for pharmacy, for example. It wasn't as much as could have been done for that element of the leadership. And I think particularly for people working in NHS providers, it can be quite limited what's available to people. So I think more could certainly be done to help support and inspire people to become health leaders, and also help support you in leadership qualities in your day-to-day. Because a lot of health professionals, they take very high-level responsible roles, and you do need to keep some key leadership qualities. So I think more could be done there certainly to help support our healthcare leaders.
And if you weren't doing this job, what would you be doing?
If I wasn't in this particular role, what I'd like to be doing is something, a role around supporting service quality and service improvement, and doing a role that makes a difference either for service users or patients, and improving pathways and how things are delivered. And my always goal to try and achieve is to try and leave things better off than I found them. I've made a positive difference. So I'd like to be in a role of that nature, but wasn't doing this particular job.
And what is your advice to future pharmacy leaders?
I think key thing really is, for me, is don't be scared to try different things and get outside of your comfort zone, because I think the best things I've been able to do is taking chances and opportunities to get involved in either different areas, different professional aspects. Sometimes you will have to do things, you may not be paid for certain things, and there's a quid pro quo of your development versus financial gain. But I think some of the key things that really benefited me was becoming a part of a nice guideline committee, linking into work streams of the Royal Pharmaceutical Society when they put calls out for people to work on key work streams, getting involved in local professional networks, taking those opportunities to be around leaders and learn from them, but also to be part of those structures and taking chances when they come along. But it's all about taking opportunities to do something a bit different and something a bit new. I think if you can do that through as your professional career develops, it really opens up the opportunities of what you could move into and different scopes of where you could go.
Well, thank you so much, Stephen. This brings us to the end of this episode. It's been such a pleasure to speak with you.
I've been really great. Really enjoyed being part of this, and really appreciate the opportunity to be part of the podcast. And obviously, you mentioned with chairing the roundtable event around the future pharmacy workforce on the 8th of September, between 6:30 and 8 o'clock. So I really hope people can look out for the call to action and come and join us and come and be part of that important policy piece.
Thank you so much, Stephen. And I hope everyone joins us on the 8th of September, like Stephen said, for that really important roundtable. So for all our listeners, do join us for our next episode, and follow us on LinkedIn, Facebook and Instagram, and you can find the captioned version of this recording on YouTube. Thank you and goodbye.